in terms of gender, in terms of gender, I think there are two different ways that we can think about gender. There's sort of two broad sort of swathes of influence, if you like. And one of the gender differences in access to resources, so the differences that we have in relation to our risks of poverty, our vulnerability to poverty, differences in the paid work we do, the impact that has on our health, unpaid work and caring responsibilities. Gender also affects health behaviours, differences in the ways in which we do or do not do the things that support, promote or inhibit our health. And also gender differences in risk, and people have already spoken of, in particular, the gender differences in the risk associated with violence, the risk of being affected by the sexual and physical violence of others. But there's also another set of gender differences that are very much about what we in this room are interested in, which is how health policy can meet the health needs of women and men. Where services are gender blind, where they treat individuals as though they are not gendered beings, what those services will do, inevitably, is miss some of the significant differences between us. And that is likely to mean that services at times will fail to meet our needs in the most appropriate way, but also the most efficient or the most effective way. I think we also need to understand and try and bear in mind the interactions between thank you. Recovering from this cold, it's not very nice. We've got to try and understand interactions between sex and gender. So sex, on the one hand, refers to biological, reproductive, genetic influences. Gender refers to the social constructed ones. But they also interact, and they interact in terms of and at the space of our health. So, for example, lung cancer is a condition, is a disease that shows very marked differences that are both attributable to sex and also to gender. Research increasingly has demonstrated that the sex-linked influences on our risk of lung cancer impact more seriously for women than for men. Medics like to talk about pack years. They talk about sort of the number of cigarettes that are smoked over time. And at the same level of pack years for men and women are more at risk of lung cancer. And that's to do with genetic differences, that there's a difference in gene expression between women and men, which means that women's genes will mutate more readily, if you like, than men's, and that increases their risk of lung cancer. And that's an incredibly important part of our understanding of the lung cancer epidemic. But of course, there's gender differences in our smoking behaviour. There are gender differences in whether or not we smoke, gender differences in the age at which we start smoking. There are gender differences in how we smoke, whether we smoke, for example, in a hurry when we're taking a 5-minute break from looking after the kids, whether we smoke in a hurry because we're taking a 5-minute break outside the workplace, and so on. There's also sex and gender differences in smoking cessation. There's a lot of evidence that women and men smoke for different reasons, and therefore they give up smoking differently. And our cessation strategies have to be gendered in terms of understanding what prompts men and women to give up, and also what supports them in that process. But there's also sex differences. There's evidence that women, for example, process nicotine differently, and that women remain nicotine dependent for longer than men once they give up. So nicotine replacement therapy may need to be used differently for men and women because of those sex differences. So I'm using sort of lung cancer as trying to sort of develop that as an idea, a case study about some of those differences between women and men that are both sex and gender linked. What we also need to bear in mind, of course, is that none of us exist as simply a gendered person in isolation. We also are other kinds of people, and we're affected by a range of other influences. So that diagram, the idea behind that is that if we think of ourselves, if we think of it, the person that we're looking at, in terms of being at the centre of that, then they are impacted on or they are affected by a range of different influences. And gender is one of many. So we're affected also by ethnicity or by socioeconomic status, by age and the stage of life course that we're at, by sexuality, by disability, and many others. So that for every individual, while gender plays a key part in their health, we have to understand it as in terms of the intersections between different kinds of influence and how they play out at the level of the individual. So to develop the idea of the case study a little bit further, I'm going to look at obesity. which I focused, I think, because it sort of is one of those risk factors. I'm one of the people who doesn't suggest that obesity is a disease. It's not a disease in itself. What it is a risk factor which increases our vulnerability to other conditions. It's a very important risk factor for hypertension, diabetes, for heart disease, for osteoarthritis, angina. It's associated with sleep disturbance, with infertility, with mental health problems, and so on. It's a hugely important risk factor that affects very many people in the population. It's interesting as well that it also affects men and women differently. There's evidence that for men, having an elevated weight, being overweight or obese, is more significant as a risk factor for bowel cancer than it is for women. So obesity also plays a slightly different part in men and women's health. Similarly, for women, obesity is more important in terms of their risk of diabetes than it is for men. So again, trying to suggest we need to try and bear in mind that sort of combination of sex and biology and gender and socially constructed factors to understand how these things play out at the health of the individual. It also is hugely important for health services. It's a major cost to health services. People who are obese visit their healthcare providers more often for a whole range of reasons, and policy therefore needs to consider the gender differences in how obesity is experienced and the impact it has on health. Differences between women and men, this data perhaps is relatively well known. More men than women are overweight in the population. This is data from the Scottish Health Survey 2008. So 42.5% of men compared with 34% of women were overweight. But the rates of obesity are similar. 26% of men and 27% of women have a BMI over 30. I'm sure you're all familiar with the use of BMI, the body mass index. There's also, although this is a very small part of the population, more women who are either very or morbidly obese, having a BMI of either over 35 or over 40. So there are differences in BMI, but BMI is an imperfect measure. If we look at another measure, which is the prevalence of raised waist-to-hip ratio, and this is where an elevated waist-to-hip ratio is defined as 0.85 and over for women and 0.95 and over for men, the data again shows that there's a gender difference in raised waist-to-hip ratio, in this risk factor for health. So across the lifespan, this is data from the British Heart Foundation for Scotland in 2003, across the lifespan, women tend to be more likely to have a higher raised waist-to-hip ratio than men, and that's particularly marked at certain ages, particularly amongst younger age groups and in later life.